All right, I have the pleasure to welcome Dr. Vanu Menon up to the stage to our next presentation. He's the director of the Cardiology Fellowship Program here, as well as the section head of clinical cardiology and the director of the Cardiac Intensive Care Unit.
Thanks so much, and Amanda and the rest of your colleagues in heart failure, congratulations on restarting this program, because I think it's a fantastic event and I hope it will continue. My talk is titled Collapse to Comeback, and we just heard about that in our previous patient, who really shows how these catastrophic events can just come out of the blue. And if you were to intervene appropriately, you can have a very meaningful quality of life after that. When we talk about primary cardiac causes of collapse, you can really divide them into three buckets, right? You can have the primary ischemic bucket, the bucket of cardiomyopathies that most folks in this room are very interested in, and then primary electrical disorders. What I was going to do today was spend a little bit of time talking about the current ACS guidelines that just came out and focus on some things about cardiac arrest and revascularization in that setting and how that's changed, and then go on with three caveats that I believe one needs to incorporate to improve outcomes when people have cardiovascular collapse as described. I think the first problem that we have is that when someone like me stands up in front of an audience and is asked to choose a case of cardiac arrest, I pick something like this. So here's a 42-year-old man out on the field, has a sudden cardiac arrest, goes into VFib, gets resuscitated, EKG shows ST elevation, comes into the lab, proximal LAD occlusion, analyze the LAD with beautiful flow. And then we see that he has got significant LV dysfunction and is in shock in that setting. Quickly, apart from revascularization, use adjunctive temporary mechanical support. And then we find something like this. I hope I can just move that along. Can you just tweak that? Because if you can just press that image, please. Well, if you can't, that's fine. It shows completely normal LV function, something that's really dramatic in terms of recovery. And this is a rare scenario. We don't see that too often. The truth of the matter is, if you have an out-of-hospital cardiac arrest in the United States, the likelihood of survival is 7 to 8%. Okay. It also depends on which zip code you're in. So if you're in inner city Detroit, you might as well have rigor mortis before you're found. Whereas if you're in Kings County, Seattle, you might do a whole lot better. Now, we understand that all cardiac arrests are not the same, and your prognosis really depends on so many factors and variables that go into it. And some of those are highlighted in this cartoon that Dr. Tamis and I had in a recent AHA scientific statement, right? On the outside, it clearly depends on, was it a witnessed arrest? How effective was CPR? How soon could we get return of spontaneous circulation? What are your metabolic parameters like in that setting? And so really, prior guidelines for guiding revascularization in this setting were pretty dogmatic. It was just all patients with ventricular fibrillation and STEMI need to go to the cath lab, class 1A indication. And what that led to actually was, one, well-intended interventionists doing all they could when we clearly understood that a whole lot of the morbidity in this setting was due to anoxic encephalopathy. And so for that reason, when you take a look at the current guidelines, we are a little more nuanced in terms of how we approach revascularization in out-of-hospital cardiac arrest, primary VFib. I think it's a big difference. Do you wake up after arrest or not? If you wake up, you get primary PCI. I mean, that's because you need to go into the lab. You got an electrical instability. We open up your coronary artery. If you're comatose, we ask the question, are the conditions favorable? And if it's favorable, you should certainly go to the cath lab. But there are a group of patients where it is nebulous. We are uncertain. None of these variables are in totality. And because of the rates of anoxic encephalopathy in this setting, we actually give the operator And we hope the operator will be biased to doing more procedures, but we give it a 2B indication in that even if you have unfavorable circumstances, we would strongly suggest, because the benefits probably outweigh the risks, that you consider PCI. But then if the pH is 6, 8, and this is a 55-minute resuscitation in an 84-year-old man, then perhaps not pursuing further revascularization is the appropriate thing to do. In contrast, and I don't want you to read this, we have a whole lot of data in non-ST elevation myocardial infarction where we've done 6 clinical trials where we've actually looked at how soon should people who have an out-of-hospital cardiac arrest in this setting go to the cath lab. And in all of these studies, we have been unable to show a convincing benefit of revascularization emergently in this setting. And so the current guidelines in non-ST elevation MI do not favor emergent angiographic definition, but favor a delayed definition in those who are neurologically intact. The one thing that I wanted to bring up, because I knew there'd be a lot of heart failure folks in the room in this setup, was we're going to certainly have a talk on the DANGER trial, which really has moved the field of temporary mechanical support in this setting by showing us that in cardiogenic shock in this setting, and most people who have a cardiac arrest are in shock, the use of an impeller is associated with significant improvement in mortality and 6-month outcome. What I want to, however, highlight is a question that comes up, is that when you take a look at all the trials that we've done with shock, you can see that even using a DANGER-like strategy, the mortality rate remains very high. That's one. The mortality rate in the placebo arm, despite getting PCI, is about 50%. But where the benefits of DANGER accrue are in that delta time between month 1 and month 6. You can see the difference in the placebo and treatment arms. So clearly, this strategy is a strategy where what you're doing in the cath lab is creating a substrate that then over time recovers to cause benefit. And what that brings up is a really important question, because when you take a look at the number of people with cardiac arrest in all of these studies, you can see that in all the 3 negative studies of mechanical support in this setting, the rates of resuscitation are 50%. It's 28% in the DANGER shock trial, and it's 28% in the shock trial where we showed a benefit of revascularization. Further, comatose patients with cardiac arrest were not participants in the DANGER trial. And so the real question that comes up in this situation is, are the benefits of revascularization in the DANGER shock trial because of the device or because of the DANGER-like patient? And I think that's a question we don't know yet. And so I think as we liberalize the use of mechanical support in this setting, I do think that there's still a lot to learn in this situation. That being said, I want to go on to 3 major points that I would like to make for the real question asked to me as to how, as a medical community, can we improve outcomes in someone who has cardiovascular collapse? And I'm not going to stick to an out-of-hospital situation because that's not modifiable for us. I'm going to say from a hospital perspective, if you're starting a program and you want to improve outcomes, what are the things that you should consider? The first, like in any field, is prevention. And let me show you some examples of what I mean by that. This is a paper written by a colleague of mine, Dan Cantillon, on the value of central monitoring services in hospitals. Dan now is leading a large company called Massimo, which continues to work with this passion on these kinds of tools. But what Dan showed with this is that when you had a monitoring system like this with well-trained people, not only do you decrease alarm burden, but you can predict and prevent cardiac arrest. And so in the Cleveland Clinic system, all of our hospitals are under the constant watch of a group of really great professionals who are remote from any of these institutions, who have direct access to our floors, who are regularly monitoring this. Now, it doesn't take you much to know, say, the next step of this is how you import AI into this. And you can see that in the future, we're going to have increasing mechanisms to identify people in the hours before this catastrophic collapse that would warrant an intervention. The second thing is to know and create systems that predict and have a response that will impact outcomes. For this, I chose my electrophysiology colleagues. One of the things that a procedure that has really increased morbidity in electrophysiology is device extraction. We have a number of devices that have been in patients for long periods of time. Whether it's a lead recall or endocarditis, these devices need to come out. And the morbidity with these devices is not small. So shown in this slide is one of the papers that tell us about what factors really are associated with increased risk of collapse in this group. And you can see that using these models, you can really predict whether patients fall into a high, low, or middle risk strategy. And this is our feeling of what's a high risk extraction is someone who's had a long-standing device, who's had prior open heart surgery, and has a real risk, as per a physician discretion, of having issues with lead extraction. What is the response to this? The response to this is that these cases are only done with a cardiothoracic surgeon on standby. What does this mean for a system? For a system, it really means you have a cardiothoracic surgeon who could be working in an operating room doing cases actually on standby, just waiting in case there's a complication. But you need to do that when you understand that things like a SVC laceration are almost always associated with death unless you have prompt resuscitation in this setting. And so in our institution, not only are we prepared by having a surgeon as backup, we are also using this balloon that can occlude the SVC in a situation where you may anatomically disrupt the subclavian. And using that, the mortality rate with even these high risk extractions is down to 1%, which is extraordinary. The other thing to do is when you do have all these monitoring systems, the monitoring systems are still going to break down and you're still going to have to respond. And so in the Cleveland Clinic, we have a rapid response team, and you say, what's so special about that? What's special about that is that this rapid response team is specifically for the Heart and Vascular Institute, where Heart and Vascular Institute patients reside. So when you have a cardiac arrest, who responds is not a well-intended emergency room physician and a couple of internal medicine residents. Who responds is a cardiothoracic anesthetist, a senior cardiology fellow, a cardiothoracic surgeon, all of whom have the ability to mobilize the operating room, move people to the ICU, and do things extremely efficiently. There's also a system that encourages nurses to actually activate the system. So here's data over the last 4 years from this. You can see there's an increasing rates of rapid response during this process, and the rates of cardiac arrest overall have not changed. You would look at the increased rapid response and say, what a pain, right? People are just being called for all sorts of reasons. But shown here is the arrest rate in blue compared to the rapid response rate. And you can see the number of rapid responses that are not associated with arrest have increased with a decline in the number of arrests, which means that these rapid responses have aborted arrest downstream. More importantly, when you compare that data to data around the country using the AHA event survival, you can see that if in the HVTI and in the Cleveland Clinic main campus in general, if you were to have a cardiac arrest, your mortality rate compared to the national benchmark is at least 10 points lower because of the response of this team. So lesson 2 is be prepared. Next one is you got to recognize the etiology. Just treating blood pressure, responding to treatment is not adequate. I think when you have an arrest, the most important thing is how do you intervene on the primary issue? And the primary issue, whether it's a massive pulmonary embolism, whether it's a pulmonary edema, whether it's a papillary muscle rupture, really depends on rapid identification by a professional who knows what they're doing. What happens if you don't recognize it? Here's a case of someone who has a cardiac arrest. Everything looks okay on the echo, but what the folks did not see was that the right atrium is invaginated. This is a person 8 days after an aortic valve replacement. CPR was done. They put a TEE probe later and found a big clot occluding the right atrium, but we weren't able to recognize that collapse in time. So this person dies, and you can clearly see there's a clot compressing the right atrium, just like we saw. A little plegited suture had given way. Small drops of blood going into the pericardial cavity results in death 8 years later. So there's a price to pay if you don't respond in time. And that's why we use a shock team, because I think we have a multimodality response where a group of people, really professional folks, can identify the cause and react in terms of a mechanism of how to treat it, and then transfer that patient as quickly as possible to a tertiary center like ours. The last part is, despite doing all of this, arrest may happen and does happen all the time. And I think what's important about it is that there is a science to post-arrest care. The ICU is no longer a quiet place like this where we treat myocardial infarction. It's this really chaotic environment where we're treating people with multiple comorbidities. And what we've recognized is being cardiocentric in the ICU, although it's called the cardiac ICU, is not enough. People are dying not because we can't treat the heart. People are dying because we can't treat end organs that are being damaged in the setting of cardiovascular collapse. And so what that takes is a recognition that post-ICU care is a science. We need to be really concerned. Are we over-oxygenating the patient? Are we using appropriate ventilation? Are we neuroprognosticating the patient appropriately? And that's a science that I don't have time to discuss today, but I do think that it belongs in the hands of people who think about it all the time and who do it all the time. And so in that setting, I think it's really important for who I believe should be running a quaternary ICU. I think that should be the responsibility of someone in a field like cardiac critical care. And I do think in this audience, an ideal person for the cardiac ICU of tomorrow is someone who is trained in heart failure and has also done, not part-time, has done critical care, because with that kind of a training, you have access to devices, you understand temporary support, but you also understand the exit strategy that is required when people come to that extremis. So as someone who lived through that era, if I could do it again, this is what I would do. I'm just a simple CCU doctor. And so the people who follow will be folks who are trained in both cardiology as well as critical care. And they're going to change the field for tomorrow. So thank you.
All right, next we'd like to welcome Dr. Anthony Zaki to the podium. He's one of the heart failure and transplant surgeons here at the Cleveland Clinic. Thank you.
Thank you. So I'm so happy to be here. But my talk is Fixing the Flow, Revascularization for the High-Risk Patients. I'm grateful to be one of the new cardiac surgeons here at Cleveland Clinic. I work closely with everyone here, taking care of these very sick patients. And a question that often comes up is, well, they're either in smoldering shock or they're out of shock, but are there opportunities to revascularize? And what's the best approach? And how do we get these high-risk patients through? So that's what we'll talk about today. So my objective is, let's review the role of CABG in ischemic cardiomyopathy, and then try to figure out how to balance the risk of surgery with the potential benefit, because these are often the patients that benefit the most, but they're the highest risk. And then we'll talk about some strategies to reduce that risk and focusing on early MCS. So just to review, very obvious for all of you, ischemic cardiomyopathy is what we're talking about. Kind of the key issue is myocardial ischemia leading to LV dysfunction. And if you're to kind of broadly characterize that into two categories, you have non-viable scar, which is, non-viable cell death that is really irreversible. And then you have hibernating myocardium, either due to repetitive ischemia. There's been some adaptive mechanism at a cellular level that's caused that muscle just to have some contractile reserve. It's viable, but just not engaged as well. Ischemic cardiomyopathy, it's a leading cause of heart failure, increasing prevalence. As people are surviving shock, they're surviving acute MI, but they're leaving with some degree of ischemic cardiomyopathy. And that's kind of, that is increasing as we're getting better at acute MI care. And the presence of CAD and heart failure, it confers a worse prognosis. These are the patients who are vulnerable to sudden cardiac death, arrhythmias, and recurrent MIs. So let's start with a case to kind of frame our discussion. This is a 50-year-old man that I met recently. He kind of has the typical coronary risk factors: smoker, peripheral vascular disease, diabetic, poorly controlled. He's only 58, and his predominant symptom is heart failure, not angina. And he's not having MIs, it's heart failure. Okay, let's see if the cath will play. All right, you'll have to take my word for it. Here's his cardiac cath. He has a CTO of his LED and his RCA. Those are chronically occluded. They've been out for some time. You can get a sense also that his LV function, oh, there we go. Okay, so you can see the RCA is out. And his circ system in the forefront on the left image has severe disease. And look at his LED on the top on the left. It's like a string, probably out for a long time. And doesn't look like a great target. And you get a sense that the LV function is just poor. So he's 58 years old. He's a diabetic. I get the call saying I have a great candidate for surgery for you. So he's got an LVEF. He's a 20%. He's got ischemic MR. You can see on the left image there, his apex is out. That makes sense. His LED was just probably out for a long time. And then, so these are our options. Do we go forward with CABG? Do we try with CABG with some kind of MCS backup? Or is this patient too far gone? He's going to be better served with an LVAD or a transplant? Or how about PCI? Let's buy him some time, save our sternotomy for his transplant or whatever he needs down the road. Or should we just go forward with GDMT? He's not having angina. There's probably no ischemia. Let's just put him on some good meds and see what happens. So honestly, pros to cons to every approach. So just to review, this is the Stitches trial, which I'm sure all of you know. This is the 10-year follow-up data. It was kind of published in 2016 New England Journal. And this looked at patients with ischemic cardiomyopathy who were surgical candidates and compared it to medical therapy alone. I think the exclusion criteria are important because these are patients who did not have angina. So these are mostly heart failure patients. And these are people that had severe multivessel disease, but not left main disease. And there was, at 10 years, a survival advantage of CABG with reduction in hospitalizations, cardiovascular death, but it came at this upfront cost of a 3.6% CABG mortality. And so if you're the STS and you tell the STS I have a 3.6 CABG mortality at my center, they're going to give you 1 star, 0 stars, and probably put you on probation. So CABG mortality is so highly scrutinized with a mortality less than 0.5%. So what is the real, there's a lot of hesitancy to take on these cases and to try to get them through surgery. But if they survive that initial hazard period, there is a potential long-term benefit. So when thinking about CABG versus PCI in this population, CABG has the proven survival advantage in an RCT platform, more complete revascularization, protection against future MIs, and it does allow us to fix usually the mitral valve. A lot of these patients have ischemic MR, and that's what's making them symptomatic. So we can fix that. PCI also has a role. It's less invasive. There's less upfront cost, and it avoids that early hazard phase. But as most of you know, in the revived BCI S2 trial, at least in 3 years, didn't really show a survival advantage. But I think there's still a role, especially in treating angina. So why is CABG underutilized in ischemic cardiomyopathy? Well, often coronary disease is not tested in new onset heart failure. So this is just, it's a non-ischemic dilated cardiomyopathy, and there's no, any testing for CAD. And when it's found, these patients are often not revascularized, and that's due to this high perceived surgical risk because of LV dysfunction. And so severe cardiomyopathy is the primary reason why these people are turned down, but we know that these are the people that benefit most from surgery. Younger patients with the lower the EF, the higher the potential benefit. So many, surgeons, physicians, cardiologists, and patients themselves, they don't want to take on that upfront risk, even though there's a long-term benefit. So how can we mitigate that risk? This is data from Ed Soltes. He was here looking at post-cardiotomy shock, so after surgery, cardiogenic shock, and looking at the STS data with patients with an EF less than 35%, all CABG comers, there was a 7.5% risk of cardiogenic shock post-pump. And if you added a mitral valve, that almost doubled or more than doubled to 16% of cardiogenic shock after surgery. And why is that relevant? Well, if you look at mortality alone in the red there, if you develop post-cardiotomy shock after your CABG or your CABG mitral, your mortality goes up from a 5%, which is high to begin with, up to a 30%, and that's 30-day mortality. So it matters. The people who develop post-cardiotomy shock after surgery, that's the reason why they're not realizing that long-term benefit. It's because of the perioperative risk. And here visually, you can see that in the first 10 days, it's when that curve really drops off. If you develop post-cardiotomy shock, that's when the survival really drops off. So how do we avoid it? This is kind of the key of what my message today. It's really about risk stratification, optimization, and early MCS strategy, and then having some kind of exit plan. And these are complex decisions. I see a lot of our nurse practitioners that help with our surgical consult team, Sandy, Roz, Brian. So there's a lot of variability. There are complex decisions, and they're best made in kind of a multidisciplinary platform. And thankfully, I work with some amazing cardiologists that help with these decisions. So the first thing that we do with the defining risk is looking at the patient overall and seeing how advanced is their heart failure. Is this new onset heart failure, long-standing heart failure? Have they had multiple procedures or hospitalizations? And kind of where do they fall on their natural history curve? And that helps us understand whether they're more advanced or whether this is a revascularization might be worth it. The most important thing as a surgeon that we look at is coronary targets. So you can see on the left, that's a high-grade proximal lesion. There's a very, robust vascular bed beyond that blockage. And so we can be able to recruit a significant degree of myocardium with a simple bypass to one of these circumflex branches. On the right there, you can see that's an RCA with the kind of diffusely diseased. There's nowhere really good to graft. I would argue, actually, that's not too bad of a graft. This is from a paper I pulled. Maybe that's not Cleveland Clinic bad quality target, but it's not great, I will say. And so that's the first thing that we look at as well. And whether that disease corresponds to what we're seeing on the echo and on the MRI. There's a lot of people that have a mixed picture because coronary disease is so common. So how to correlate the disease with the dysfunction. We look at the LV size, the LVEF. This is a paper, that graph here that shows that if your LV end diastolic dimension is greater than 65 millimeters, 6.5 centimeters, then the risk is increased after surgery. A lot of these patients have apical ekinesis due to LED disease. This was a clot that we pulled out a few days ago at the time of CABG from someone's LV apex. We also look at viability. Viability is a very kind of controversial topic. We don't make any decisions based on viability alone. But I think these are complex decisions, and another piece of information helps. So often we do an MRI or a PET scan. Those are our preferred modalities. We look at wall thickness, degree of, kind of how much transmurality has the scar involved, and what's the chance that we can recruit that muscle post CABG. The most important marker of viability to me, though, is angina. So if you have, it doesn't matter what your EF or your LV size is, if you have angina, you have viability. And a lot of the people that trained me says, if he's walking around, they're viable. So, viability it's important, it helps, but we don't put a lot of weight on it. I just recently took a guy with zero viability in his LED region. That was the LV clot that I showed on the previous slide. And we were able to recruit a lot of peri-infarct muscle by doing a limited LED bypass, even though the PET scan said he had large LED scar. Most importantly, for me, is the hemodynamics. This is a paper that one of our chief residents published recently. This is looking at what are the predictors of post-cardiotomy shock on a hemodynamic evaluation. And the number one thing, believe it or not, is PAPI, or RV function. So, and that is the variable importance is almost double that of or almost 5 times that of the other variables. And so this kind of tracks with what the senior surgeons have taught us, is that the LV function is important for long-term prognosis and benefit, but it's your RV that gets you through surgery. And that's kind of a pearl that we all learned getting through residency. It's your RV that gets you out of the operating room, and it's your LV that gives you the long-term survival. So if you're PAPI, if someone's coming in with a CVP of 25, their PAPI is low, even if you have great viability and great targets, you're going to struggle. And those patients we optimize. They come down to J31 with a lot of our crew here, and they get swans, they get diurese, they get decongest. We prefer nipride over inotropes to kind of minimize myocardial oxygen demand. And we use MCS preoperatively pretty liberally if needed to get these patients into through surgery. So breaking this kind of complex decision process up into 3 questions. This has helped me immensely kind of thinking it through it this way. I wanted to share this with you. The first question, is surgery safe? Is surgery safe? So we look at the STS score, their age, what comorbidities do they have? Can I get this patient through surgery? If not, then we don't operate. We consider other alternatives. The second question is, well, if I can get them through, but are they to benefit at all from the operation? Or will this just be a technical exercise? So the second main question is, will it be beneficial? We look at the targets, the viability, the LV size, and that answers our second question. If really it's not beneficial, then we don't subject to the risk of surgery without any meaningful benefit, and we kind of save the sternotomy for later if needed. And then the last question is the patient optimized. And oftentimes we can only optimize to up to some point. I have a very low threshold to ask them to go get a swan and get diuresed and even put a balloon pump or an Impella preoperatively to try to optimize, because the better the numbers are going in, the better you are coming out. So this is a framework that really helps make these complex decisions, is asking these 3 questions. In the operating room, what we really care about as surgeons is to be quick, to protect the heart well, to limit ischemia, and minimize bleeding. These patients really don't have much reserve. So it has to be a perfect operation and it has to be quick. And then you can't leave anything behind. You can't leave a vascular bed ischemic. You can't leave MR 2 to 3 plus. You can't leave AI 1 to 2 plus. Everything has to get fixed, and you have to do it quickly. So that's some of the things that we think about as surgeons. Now, traditionally, if you do this operation, and even in the best of hands, they're sick patients, things may not go well. And so the traditional approach was to kind of put them back on pump, rest things, kind of check your valves, check your grafts, make sure everything's okay, optimize as much as you could, and then try again a little bit later once you've been on pump for a little bit more time. And then, and meanwhile, the anesthesia is cranking up the inotropes, the pressors, and now you're adding, well, I got to do a balloon or ECMO. We're still not doing well, but I'm definitely not putting an Impella in. That's hard work. I just went through this whole operation. I don't have time to do, or I don't have the energy, or this patient can't tolerate more. So this is kind of our traditional approach, and unfortunately, it doesn't really work. These patients, it's more time on bypass. There's more bleeding. There's more ischemia, and these MCS platforms that we'll kind of talk about are limited. So starting with the balloon pump, it really has a minimal effect on your hemodynamics. It may get better flow down your grafts, but your increase in cardiac output is pretty minimal. Secondly is VA ECMO. This is kind of the surgeon's go-to. It's easy to put in. You already have the cannulas in for bypass, so just switch them over to ECMO. The problem is, as many of you know, ECMO is a massive afterload to the heart. And just yesterday we had an unfortunate case where a surgeon did a complex redo, severe LV dysfunction, said, I'm going to rest this patient on ECMO for 1 or 2 days. And before they left the operating room, the LV formed diffuse clot, and unfortunately, that patient expired. So it's VA ECMO. It does provide full support, but it does come at a cost. It does definitely come at a cost. Now, in Impella 5.5, the main advantage here highlighted there is that it actively unloads the LV. So the LV end diastolic pressures come down. You're getting an increase in forward flow. Your lungs are decongested. And so this is kind of our preferred platform to get people through this operation. It can be placed either in an axillary position, which is a small incision, kind of the right deltoid pectoral groove. And that can be done preemptively, preoperatively, or after surgery. And very easy to do. And also more recently, we've been just putting it directly on the aorta. This is a complex case we did a couple weeks ago. We just put a side biter clamp on the ascending aorta, sewed the graft there, and do a tunnel incision out in the neck and put the Impella in. So I don't think there's not much of that initial buy-in that you have to overcome to put an Impella in. So what do we do after that? We extubate early. The patient's on an Impella. It's either axillary or aortic. They can get out of bed. They don't have anything in their groins. We walk them. We wean the pump slowly, usually up to 2 days to 7 days, depending on how much time they need. And then we remove it. Their chest does not need to be reopened, even with an aortic Impella. We can often do it in the ICU under local. And then we get them on GDMT as soon as possible. So back to our case, this is our guy here. We saw his cath, his echo. He got a right heart cath. He does have pulmonary hypertension, but the first thing that I look at is his RV is good. I mean, his PAPI is 3. So I know this patient will get through surgery, and his wedge is 26, and his index is borderline. So this is someone that stands to benefit, he's relatively optimized, and he can get through the operation. Now, will he derive any benefit? His LV size is 5.7, so not massively blown out. He does have apical kinesis and thinning, no LV clot, and there's just a small amount of apical scar. So I know that the rest of that LED, if I can somehow get a good target on there, is going to come back. So we took him, he's 58, we did multi-arterial grafting, a LIDA LED, a radial to the circ, and a vein graft to the PDA. We repaired his mitral, and then up front, instead of just trying to see how he does, we put in an Impella 5.5 directly in the aorta. He did very well. It came out on very minimal support because of the Impella. In the past, this would be epi, milrinone, inhaled Velitri, stay intubated for 3 or 4 days. But he was extubated the next day, and the Impella was moved day 3, and he was sent home on day 8. And then this is his echo at 3 months. His apex is still not stellar, but his LVEF is 40%, and his MR is gone. So this is a patient that most likely, due to poor targets, minimal viability, may have been turned down in the past, but we can get them through surgery with these kind of tricks. So to conclude, CABG improves survival in ischemic cardiomyopathy in patients who can survive that early hazard phase. And we have our systematic approach here to optimize and to stratify risk. And we really have liberal use of the Impella 5.5 to kind of unload these patients and get them through surgery. Thank you.
Thank you so much. We now move on to Dr. Ran Lee, who's going to be talking about the right ventricle in the setting of shock. We're very fortunate to have Dr. Lee here, who is boarded not only in cardiology and heart failure, but critical care, and is our Associate Director of the CICU and APD in the fellowship program.
Good morning, everyone. Afternoon now, actually. Thank you for that kind introduction. Thank you for having me here. We'll be talking about getting shock right. And I put a little twist on the topic because as much as we want to emphasize left ventricle versus right ventricle, it's all about managing the proper ventricle in your shock setting. So we'll review the latest definitions in epidemiology and outcomes of cardiogenic shock, different management strategies escalating from profiling, pharmacologic support, all the way to temporary mechanical circulatory support, as well as review LV and RV specific management of shock. So cardiogenic shock in 2025, not all is created equal, nor should be approached the same. It's a high driver, stubbornly, of high mortality and morbidity. So it's very important how we diagnose, define, stage, and manage it, and try to find what we're missing to improve outcomes. I'm not going to go over this chart in detail, but always trying to define the etiology is what we usually start with, whether it's myocardial, valvular, electric, obstructive, or systemic causes of cardiogenic shock. But I always look at cardiogenic shock as beyond that. Is it involving both my ventricles? Is it LV dominant? Is it RV dominant? The definition of cardiogenic shock, as you all know, is a primary cardiac disorder leading to a low cardiac output state with ensuing clinical and biochemical evidence of tissue hyperperfusion. However, we never really defined it very well beyond that in historical controls. And these were based on trial data, shock trial, IVP shock trial, which really limited our assessment to blood pressure, cardiac index, filling pressures, and end organ perfusion. In 2019 and 2021, authors, including Dr. Barron, who's in the audience today, came up with a new definition and staging system so that we all spoke the same language so that we can all understand the shock that's in front of us. So the SKY shock system of staging cardiogenic shock was pretty simple in concept. At-risk shock, beginning shock with clinical evidence of hemodynamic instability without hyperperfusion, classic shock, deteriorating, and extremis shock. We know the shock when we see it in front of us. What it looks like on a granular level really comes down to, okay, well, hemodynamic instability without hyperperfusion is defined as beginning shock, hyperperfusion requiring intervention defined as classic shock, deteriorating and extremis shock, which we all know. But the real emphasis of what we see day in and day out in our cardiac intensive care units are classic and deteriorating shock with high heart rates, low blood pressures, the implementation of devices and drugs, high lactates, high filling pressures, low cardiac index, and most importantly, end organ dysfunction. Cardiogenic shock mortality, both in the ICU and in the hospital, remains upwards of 30 to 40%. It is worse in both MI populations as well as heart failure populations, and it's really bad when it's mixed with another process such as distributive shock. Because it's a heart failure summit, I do want to emphasize the rapid proportion increase of heart failure cardiogenic shock. This is data from Critical Care Trials Network, C3TN, looking at a cohort of admissions across 28 centers across North America. Already starting off the bat, you have a primary cohort of heart failure cardiogenic shock. That's about 70% of total values that are obtained here relative to AMI cardiogenic shock. In patients with acute on chronic heart failure shock versus de novo heart failure shock, there are more of them, but the de novo heart failure shocks do worse. They have higher proportions of SKY stage D and SKY stage E cardiogenic shock and higher proportions of cardiac arrest as well. Besides that increasing in prevalence of heart failure shock, we can't ignore AMI shock because if that happens in up to 8 to 10 cases of patients presenting with ST elevation MI, it is the most common cause of in-hospital mortality among those patients and remains something that we can't ignore as well. We all know that cardiogenic shock is a hemodynamic problem to start, high filling pressures, low cardiac index, that rapidly progresses to a hemometabolic problem, systemic inflammatory response, cytokine release, bacterial translocation. Heart failure cardiogenic shock is different. There's more progressive deteriorations. There's less common pathways to native heart recovery. There's more common pathways to heart replacement therapies. And as you can see here in red, individuals will have recurrent hospitalizations, recurrent deteriorations. The pathophysiology is different as well. There's more long-standing ventricular dysfunction, peripheral hypoperfusion, neurohormonal activation, as well as baroreceptor activation, splenic vasoconstriction, arterial vasoconstriction, and the defining feature of all our patients in heart failure, congestion. Phenotyping this cardiogenic shock is the next step in how we take care of patients, either by perfusion phenotyping or volume phenotyping. So this is a classic spin on the Diamond-Forrester plots of warm and wet heart failure, cold and wet heart failure to cardiogenic shock. Classic cardiogenic shock with low cardiac index, high filling pressures, cold and dry cardiogenic shock, so low output states without necessarily high filling pressures, and warm and wet cardiogenic shock or a mixed shock state with distributed processes. We've started to put an emphasis on phenotyping by ventricle as well. And this is from a state-of-the-art review in Journal of Cardiac Failure that's kind of defined RV predominant shock with a CVP greater than 14, a wedge less than 18, CVP at a wedge ratio greater than 0.86, and a PAPI less than 1.5, and a cardiac index less than 2.2. Why is this important? Well, data from the Cardiogenic Shock Working Group really shows that in patients across their centers with invasive hemodynamic monitoring, individuals with BIB congestion as well as RV congestion had higher in-hospital mortality, both in myocardial infarction shock groups as well as heart failure shock groups. And biventricular congestion was associated with increased higher SCAI stage severity. How do we define right ventricular shock? Well, again, go back to etiology. There's an acute form of RV shock, typically either RV myocardial infarction, myocarditis, post-LVAD RV shock, and a chronic phase, more so from inherited diseases such as Epstein anomalies, arrhythmogenic right ventricular cardiomyopathy, or predominantly RV cardiomyopathies greater than LVs. How do we define hemodynamically what RV shock looks like? An RA greater than 15, RA to wedge ratio greater than 0.86 after an MI or 0.63 after an LVAD. And then most importantly, as Dr. Zaki emphasized in the previous lecture, PA pulsatility index or PAPI, defined as less than 1.85 as a predictor of RV failure post-LVAD. There's much to do and to talk about the PA catheter. These are the founders, William Gans and Jeremy Swan, publishing their seminal paper in the New England Journal in the late 60s. But it got a bad rap in the 2000s. This is data out of Duke with a decrease in Swan-Gans catheter utilization over time. But it's made a comeback in the 2010s with many papers written over the value of invasive hemodynamic monitoring in patients with cardiogenic shock, as well as patients with temporary mechanical circulatory support. So why is that? Are we recognizing these patients better? Are we selecting these patients better? Are we interpreting the data better? Because at the end of the day, it remains a diagnostic tool over a therapeutic delivery method. Data from the Cardiogenic Shock Working Group really emphasizes that complete hemodynamic profiling with all four of pulmonary artery systolic, pulmonary artery diastolic, wedge, and pulmonary artery saturation data coming from your invasive hemodynamic monitor was associated with decreased mortality amongst patients with cardiogenic shock, even at the higher stages of severity. So what do we do with all that information? Well, beyond defining your hemodynamic phenotype, trying to figure out what that therapeutic strategy after the fact gets to be the next step. So what do we do with warm and wet heart failure? Well, we do vasodilate them, we diurese them. What do we do with cold and wet heart failure? Well, we try to warm them up. Vasodilators, diuretics, and inotropes when hyperperfusion persists. However, if they're in persistent shock with a blood pressure less than 90, utilization of short-term vasopressors is recommended, but only from a short-term perspective, and then quick escalation to mechanical support for refractory purposes. So how I manage a patient with either left-sided or right-sided cardiogenic shock, I want to stabilize hemodynamics and tissue metabolism. I want to preserve end organ function and perfusion. I want to minimize that myocardial workload on an injured heart and try to facilitate some sort of recovery. And I want to utilize medical and device therapies to bridge to a destination if recovery is not feasible. And above all, I want to minimize that iatrogenic injury from these therapies. Beyond history and physical and studies, I do want to emphasize the utility of bedside ultrasound and point of care ultrasound in the ICUs to get a sense of what we're looking at. And most importantly, defining that hemodynamic profile of cold and wet, warm and wet, mixed, or cold and dry. Invasive hemodynamics with an indwelling PA catheter, really honing in on the fact that SCAI stages B and C are stages of opportunity for us to prevent deterioration and to try to catch all of these end organ processes before they deteriorate. However, it is a diagnostic tool. You need to know what information you're deriving and how it'll change your management, whether it's vasoactives, guidance on escalation or de-escalation of devices, and knowing that garbage in is garbage out when it comes to information and monitoring the trends that are derived. Maintaining a MAP goal greater than or equal to 65 millimeters of mercury, optimizing your preload and cardiac index greater than 2.2, that constant attention to an underlying etiology. I want to touch briefly on pharmacologic management. Sodium nitroprusside is our go-to for quick acting vasodilators. Norepinephrine greater than dopamine in the setting of needing a vasopressor in all types of shock, and really being agnostic on the fact that dobutamine and milrinone, when compared head-to-head in patients with cardiogenic shock, showed no difference. The bottom line with all these pharmacologic tables is use what works, know the risks, and have a backup plan. So how I manage a patient with RV-specific cardiogenic shock, targeting a CVP of 8 to 10, making sure that there's restoration of sinus rhythm or AV synchrony, that RV really likes that atrial kick, RV inotropy if necessary, RV afterload reduction if necessary. This is a complicated algorithm, but it's a very useful reference from a scientific statement on evaluation and management of right-sided heart failure in Circulation in 2018, really kind of going over etiology-specific reasons, maintaining AV synchrony, minimizing arrhythmias, optimizing that preload on the right side from 8 to 12, and maintaining perfusion with MAP and cardiac index. But we've now escalated from pharmacologic support to a lot of guidelines, whereas we didn't have before on how do we support either the right side or the left side when it comes to temporary mechanical circulatory support. The things that I think about when we have to take that step: which ventricle is involved? Do we need to support the lungs as well? What is feasible anatomically, and where are we going? Is this a bridge to recovery, a bridge to treatment, a durable destination, or ultimately a bridge to palliation? From a mechanical circulatory support perspective, the ideal device is easy to implant, easy to maintain, easy to remove, allows for ambulation, it's hemocompatible and durable, and it's cost effective. No such device exists, unfortunately, but all of these things we do have to weigh. From the heart failure perspective, a lot of our guidelines show the indications for why we would need to use temporary mechanical circulatory support devices. Acute cardiac allograft failure, post-transplant RV failure is high on the list and unique to the heart failure population. From an escalation and de-escalation pathway, on the left-hand side is an algorithm to manage heart failure, cardiogenic shock, and on the right-hand side, how to manage acute myocardial infarction cardiogenic shock. But from a severe refractory shock perspective, the emphasis on consulting your multidisciplinary shock team is ever present, and reassessing that shock profile with invasive hemodynamics, defining whether or not it's right-sided, left-sided, biventricular is of emphasis. A lot of different charts out there exist on the different types of flows that are provided from left-sided specific devices such as balloon pumps, Impellas, tandem hearts for the left side, or right-sided devices such as direct bypass mechanisms, Impella RPs, or RA to PA pumps, or indirect bypasses such as VA ECMO. But this Venn diagram really gets you a sense of, is this cardiogenic shock with predominant RV failure where we can just get by with a Protect Duo or an Impella RP Flex? Is this cardiogenic shock with predominant LV failure using one of the left-sided devices? Is it biventricular, and whether or not we need respiratory support or not, which lands you at VA ECMO in the center, and whether or not you just have respiratory failure without any cardiac process, which lands you to VV ECMO. We always need to consider the right device for the right patient at the right time. As soon as that device goes in, we have to think about exit strategy and de-escalation mechanisms, and utilizing that multidisciplinary team to help guide that. The different types of RV-specific supports have been updated in this graphic out of JHLT in 2024. Not only do we have Impella RP coming from the groin, we also have Impella RP Flex coming from the right internal jugular as direct bypassing of the RV flowing from the RA and SVC to the PA, decreasing that RA pressure, but potentially increasing your mean PA pressure as well as your wedge pressure. Or you can have indirect RV bypasses such as VA ECMO, which decrease that RA pressure, but at the cost of increasing your LV afterload. From a direct RV bypass hemodynamic perspective, Impella RPs, tandem RVADs, Protect Duos displace blood from that right atrium to that pulmonary artery, skipping over a failing RV. And what hemodynamic in vivo studies and in vitro studies show is that it increases your aortic pressure, decreases your RA pressure, but can increase your PA pressure. So in individuals with pre-existing elevated pulmonary vascular resistance or pulmonary hypertension, it is something to keep in mind. From an indirect RV bypass perspective, what VA ECMO does is drain from the RA, oxygenate, transfer blood back to the aorta. So you have an increase in aortic pressures as well as a decrease in RA pressures. I'm going to end on a case to really kind of emphasize how we utilize a multidisciplinary shock team as well as ventricular specific devices to get patients to their ultimate destination. This is a 56-year-old man with a PKP2 mutation positive arrhythmogenic right ventricular cardiomyopathy who presented with acute on chronic right ventricular failure with progressive markers of sky stage C to D shock biochemically, as well as hemodynamic measures that confirm that with an RA of 18, a PA of 32/20, so a PAPI less than 1, a wedge of only 14, but a cardiac index of 1.4. This is what his echocardiogram looks like with severe RV dysfunction and dilatation and a small LV with a septum that's being bowed into it. We activated our multidisciplinary cardiogenic shock team and decided upon an Impella RP flex insertion in the OR with cardiac surgery as well as heart failure intensive care. This is what the ventricle looks like post RP flex insertion, flowing 3.3 liters per minute. On the X-ray on the right-hand side, you can see the tip of the Impella RP flex with pigtail in the proximal PA after the pulmonary valve. And we were able to get this gentleman on this extended device support, ambulating, feeling well for 29 days waiting in our intensive care unit prior to getting a donor offer and successfully going to transplant with RPA Flex explant. So my summary for the last 20 minutes or so is that invasive hemodynamic monitoring, phenotyping, pharmacologic, plus device tailoring is highly recommended to guide treatment of cardiogenic shock states, whether it's LV, RV, or both. Different congestion and perfusion, as well as ventricular profiles, will guide your choices on vasoactives. And when considering escalation to temporary mechanical circulatory support, we have to take into account multiple factors: patient disease, anatomy, cost feasibility, and bridging. High emphasis on utilization of a multidisciplinary shock team is recommended. But cardiogenic shock in 2025 still has a stubbornly high in-hospital mortality and morbidity with a high economic burden. MI shock and heart failure shock remain our highest leading etiologies. And while our technology has advanced, our science has not necessarily kept up, though registries are ongoing. And in our next talk, Dr. Higgins will talk about the available RCT data on cardiogenic shock. We have a focus on this definition, staging, and phenotyping, and trying to preserve end organ tissues. Talking about regional hub and spoke models to do this as well. And that emphasis on highly protocolized care that Dr. Menon mentioned and excellent CICU management. But we do need to bolster our science in this space to try to find future targets to minimize the morbidity and mortality and improve our outcomes. And with that, thank you.
Thank you so much for the great talk. And next, we want to welcome Dr. Andrew Higgins with the distinct honor of the last presentation here of the day. He is the shock program outreach coordinator here for the Cleveland Clinic, and he's dual boarded in both advanced heart failure as well as critical care. And he'll be speaking today about the evidence base for shock management.
Thank you for the introduction. I'm cognizant that I'm the last speaker before you guys get to those refrigerated coolers with the bottle openers from Ed's talk, so I'll go relatively quickly. I'm talking about danger ahead, so looking for an evidence base for shock management. My goal is that you'll get three things out of this topic. So you'll be able to talk about what the state of the evidence is for our TMCS. I'll give you a spoiler alert since it's late, not great. You'll talk about the challenges that we've faced in building that and what challenges we're looking at ahead, and then what tools have been shown to be consistently effective in our current evidence base. So this is ECMO. So you heard from Greg here about the efficacy of ECMO. You've all seen it work. I think we do it better here than almost anywhere else, and I'm very grateful to our cardiac surgical team for our help with this. But we're not alone. And so across the nation, rates of ECMO utilization are increasing constantly. Rates of Impella utilization are increasing constantly. Globally, our balloon rates may be falling, but in specific indications, we're still using more. And so MCS is a part of everyday life, and it's going to touch on every facet of cardiology in the next 10 years. You know, we see cases like Greg's every day. We know that it works in the right patient. Does the evidence support that? Absolutely not. And so you can see here, these are data from ECMO CS that included all comers for both AMI CS and heart failure shock, randomized them to ECMO or standard of care. The curves superimpose. And so when you deploy these tools indiscriminately, you don't get a benefit. And so how do we refine our question and find the population that we need to get to and treat appropriately? This is J31 bed 16. It is just like any of our other cardiac ICU rooms. As Dr. Menon alluded to earlier, it is stuffed with devices. And how is the evidence for these devices? So looking at the Impella and the ECMO here in the room, is this an ECPella configuration? The Impella has no RCT in most contexts. ECMO has a few, and we'll talk about those. But really, it's a challenging space to work in with a lack of evidentiary guidance. And so our tools have dramatically outpaced our evidence base. As Dr. Lee alluded to, our randomized evidence base in particular has struggled. And the challenges that imposes on us are going to touch every field of cardiology, but particularly you guys in heart failure and us in cardiac critical care and heart failure in the coming years. What tools do we have? So I'm going to go fairly quickly through these. The balloon remains a stalwart of ours, 7.5 to 8 French cannula. We can put these in about 15 to 20 minutes bedside. You don't get a great deal of support. You get a little bit, and certainly we have the axillary option, freeing up the groins and helping us keep patients ambulatory and staving off sarcopenia, as Dr. Best knows is critical. But you don't get a lot of support out of it. How is the evidence for it? Spoiler alert again, not great. And so these are Holger's data from 2012 from IEBP Shock 2, 600 patients with acute MI coming in with shock, randomized to balloon or no balloon. They looked at 30-day mortality. The curves superimpose. Are there problems with this evidence base? Absolutely. And so this was a relatively not sick population. They were hungry for enrollment. They had a lower mortality than other shock cohorts. If you put a device in to a patient that doesn't need a device, you're not going to show a benefit from that device. And we'll circle back to that here shortly. We said after that, well, hey, that's AMICS. What about heart failure shock? Do we see the same thing? These are data from our colleagues at Columbia that had shown a more selective benefit in heart failure shock than AMICS. They said, hey, maybe there's a role here for the balloon, not in acute MI, but in heart failure shock specifically. This led, these are their plots of the hemodynamic response, not mortality, but hey, at least showing hemodynamic benefit and a preponderance of benefit in our heart failure shock patients. This led to alt shock 2. And so this dropped this year, was a late breaker at ACC, 101 patients in Italy that were deemed suitable for heart replacement therapy, so deemed eligible for VAD or transplantation, that were temporized with a balloon, randomized 1-to-1. They looked at survival or bridge successfully to heart replacement therapies at 60 days. Does it work? No. And so, yes, it's a durable platform. No, it doesn't seem to change outcomes. Are there problems with this trial? Yes. So they screened a lot of patients to do this. They excluded 90% of their patients. They only included patients they thought were eligible for heart replacement therapies. Dr. Varian alluded to how many patients are out there that aren't eligible for specific heart replacement therapies. So what do you tell your patient if they're not eligible for a transplant? Like this evidence base doesn't apply to them. This is a very select population. They undercharacterized the hemodynamics. Only 40% of the patients had a PA catheter, and they weren't sick. 28% of these patients were SCAI stage B with a median lactate in the trial of 1.8. That's not a patient that I'm usually reaching for circulatory support, except in specific circumstances. On the basis of these negative trials, we've derived a lot of class 3 recommendations for IABP for routine use in both heart failure shock and AMICS. But routine use is really not the question. Is it time to let go of the balloon? You guys know I love the balloon. I would say no. So if you're a balloon aficionado, there is always hope. There remains a population that derives benefit from this. And it's going to stay in our armamentarium unless Cardiogenic goes out of business for a long time. And so these, again, are data from Columbia, from my friend Justin Freed, that showed that there's certainly a population that is more likely to derive benefit. And so if you extract out your heart failure shock patients and you say, I'm looking at my ischemic heart failure shock patients, I'm looking at my patients with no RV dysfunction, I'm more likely to see a pronounced hemodynamic response. We reach for it in those populations a little bit more selectively. It has a very important role. Greg had a balloon pump. He mentioned this in helping to vent the sick knockdown LV that we placed onto ECMO. I love the Impella. Anthony knows I love the Impella. I call him at 2 in the morning for Impellas. But if I can get away with a smaller bore device with fewer complications, I would love to get away with a smaller bore device. And so the IVP very much has a role helping us to vet select ECMO cases that don't need the full flow of an Impella 5.5. And certainly we expect an augmented effect in other populations like those with significant MR. So the randomized trial data for balloon has clearly not shown a consistent benefit. The absence of evidence here does not equate to evidence of absence. Clearly, there's still a role, and we have to look beyond RCTs for more granular guidance. What about ECMO? And so certainly a bigger intervention. With a bigger intervention, we get larger cannulae. It's biventricular support, technically, depending on how you define support, rapidly deployable bedside, or a mobile truck if you're in Minnesota. And you can get a lot of support out of this, up to 6 liters a minute of flow, and we needed nearly that much for Greg here. It saves lives, clearly. If you carefully select your population, these are the Minnesota data of the ARREST trial saying that out-of-hospital cardiac arrest, carefully selected patients with shockable rhythms that were randomized to ECMO or standard of care. All of the standard of care arm is dead by 105 days. I don't love that. But if you look at and you carefully choose your population of interest, you can save almost 50% of your patients that were dead in the field. That is a huge intervention. It's been more challenging to replicate these data elsewhere. This is a Herculean effort, a heroic effort from our Minnesota colleagues, but the potential is there if we can find the population. Has the randomized data borne this out elsewhere? It's been a mixed bag. And so this is the ECMO CS trial from the Czech Republic, randomized patients with either AMI CS or HFCS, so all comers, sent them to either ECMO or conservative therapy. Sick population, so unlike IBP shock 2, quite lactatemic, on quite a bit of vasopressor. And they looked at death, cardiac arrest, and escalation to other forms of support. Guess what? The curves still superimpose. If you look at mortality alone, the curves look even more similar, but there are problems again. And so they crossed over 39% of their patients from the control arm to the ECMO arm. It's hard to watch a patient die in front of you if you have something that you think can save them, even if you think there's equipoise in that intervention. But that you're going to get a lot of type 2 error from that. You're not going to have a positive trial if you cross 39% of your patients over from the control arm to the intervention arm. It was an older population, 66, very reasonable for transplant or VAD, but it's a patient that's more likely to have accumulated comorbidities, more likely to be sarcopenic and struggle to come back from the toll that ECMO imposes on you. Mr. Levitz had youth on his side and was very healthy beforehand. You're 66, you're 70, you go into ECMO, it's a harder road back. You heard of what it was like even when you're significantly younger. And they didn't standardize their LV venting, and we all know the deleterious effects, as Anthony alluded to, of unvented ECMO in this population. What about ECLS shock? So this is 417 patients, all with acute MI, Holger's coming for all of our toys one by one. And he randomized them to either ECMO or conservative therapy. Again, very sick population, median lactate of 7. They looked at all-cause mortality. Guess what? The curves superimpose. And so again and again and again, the RCTs would say that there's not consistent data here showing a benefit. Are there problems? Yes, as always, there are. And so this is a heterogeneous population. Thanks to Dr. Barron, we have a language to talk about how sick these patients are, and I'm going to circle back to that. But 50% of their patients were Sky Stage C. I don't know about you guys. I don't put my Sky Stage C patients on ECMO except in certain circumstances. And if you indiscriminately deploy this across your Sky Stage C population, you are putting a lot of people on ECMO who never needed ECMO, and you're never going to be able to show a benefit in that context. They didn't standardize their LV venting, and again, older patients with a median age of about 70. We didn't get a lot of info from them on their heart replacement therapies, how many went on to VAD or transplant. On the backbone of this, guess what? ECMO gets a class 3 for routine use now, joining its friend, the balloon. So as with balloon pump, randomized data have not shown a consistent benefit, but routine ECMO was never the question. Nothing about our patients is routine. Everyone is unique, and we need to refine and define our population of interest. So at some point, the TMCS skeptics start to feel a little bit like this, that the aficionados here keep setting them up for success. They give us another negative trial, and we pull it away and say, hey, there were problems with that trial. I feel their pain. It led to conversations as recently as October of 23 with leaders in the field saying, is the era of the RCT dead? Are we never going to see another positive RCT in mechanical circulatory support in our lifetimes? And Dan Burkhoff from Columbia certainly took the pro position there, said they're dead. Obviously, you guys know that that's not the case, and we're going to get there. The state of the Impella evidence base leading into danger was not great. So a bunch of negative trials, all small, struggles to enrollment. Many of them stopped early, but we were kind of sensing that we weren't going to get a positive RCT in this space. Slow enrollment, low volume centers. It's not an incredibly complicated device to insert, but there's a learning curve there. And if you put this in the hands of somebody that does 1 or 2 a year, it's going to be hard to show benefit. They didn't standardize when these devices were going in. And so thankfully, Jacob Muller and colleagues set us up for success one more time and said, let's take another crack at it and see if we can get a positive result this time. And so they gave us a dangerous shock last year. Took patients who were 18 years of age or older, STEMI or STEMI equivalents, clearly sick with hypotension and evidence of hypoperfusion. They carefully excluded patients who were post-arrest. We'll touch on that in a little bit, but the patients who were post-arrest and still comatose, I'm sorry, patients with severe RV failure, patients with mechanical complications, really narrowed their question of interest here, randomized them to Impella CP at the time of revascularization, supporting them for at least 48 hours. And finally, curves that diverge. And so they showed with a number needed to treat of about 8 to save a life, a significant mortality benefit with 45% mortality in the microaxial flow pump or MAFP arm and about 59% of standard of care. They showed more bad things happening too. And so you get an uptick in your safety events. This caught a lot of attention at ACC last year. You get a longer length of stay. Your front office is going to need to be to know that that's coming if you start supporting patients for a long period of time. And they ran into more issues with dialysis. And so significant uptick in dialysis rates. They later published the follow-up to this, that these patients came off of dialysis nicely. But temporary dialysis, as in Greg's case, is not uncommon due to the ATN, the contrast load, all the things that go into a critically ill AMI-CS patient. I'd rather have temporary dialysis than die. That's just me. But it's, there are downsides to these devices and we need to take them seriously. And so we said, we're finally sprinting ahead. And then the skeptics come up from behind us with a couple of points here. So, we said mission accomplished. We've got a positive RCT. We finally exquisitely defined our population. We had a well-randomized, well-timed intervention with a positive primary outcome. But the skeptics had some good points. And so, yes, we exquisitely defined our population, but at what cost? Good luck finding these patients. And so an analysis by Connor O'Brien out of Triple CTN showed that only 32% of our STEMI shock patients qualified for the danger shock criteria. That's 5% of our shock burden overall. So great. We've moved the needle on 5% of our daily problem. We've found a well-randomized, well-timed intervention. And still, despite that, we only barely met significance. So we had a fragility index of, I think, 2. So only 2 patients would have had to cross over for this to be a negative trial. So by the skin of our teeth, we've got our first positive RCT that addresses 5% of our problem. So routine deployment of microaxial flow pump, again, does show benefit, but really specific conditions. It took them 10 years to complete this trial. Why do RCTs continue to struggle in this space? And I think that's what we need to talk about today. Camus said, one must imagine Sisyphus happy. We've been rolling this ball up the hill since the era of the original shock trial. Thank you, Dr. Menon. And so I think there are a few things to talk about that make this a particularly thorny problem to study. And a lot of it has to do with what Dr. Lee spoke about. And so there are problems with how we build these trials and how we keep reaping so much type 2 error over the years. One is failure to recognize and transfer shock early. One is failure to support quickly. One is that not all shock is created the same. And so Rand showed you those differential plots of how patients present an RV or bi-V shock. Those respond very differently to LV only support. And so not recognizing myopathic heterogeneity is a major problem. Also, we need to think about how differentially sick these patients are. And so our less sick patients do not need the devices as much. And we'll talk about that in the context of ECLS shock specifically. And then lastly, you have to acknowledge that TMCS has limitations. It can only fix certain things, and we'll go to there. So failure, recognize, and transfer. These are Jake's data out of Mayo, looking at patients who are coming in with shock in the Mayo experience, isolated hypotension versus hypoperfusion versus both. It's better, in contradistinction to what many people think, to be hypotensive than hypoperfused. And part of that is probably that when you get a systolic of 88, everybody freaks out. Versus if you sit there cold with a lactate that no one's measured, starting to make a progressive transaminitis, then you're going to run into problems over time, and no one's there to recognize it. And so hypotension is much better to have than hypoperfusion alone, although the combination is bad. Do the data bear this out? Yes. So this is data out of CSWG. We know that there's a higher mortality for patients who are transferred in from a referral center into a tertiary center, but that's driven exclusively by our heart failure shock population. And why is that? I think it's because we don't have our STEMI equivalent. And so AMICS, we've got the virtue of chest pain, an EKG that says, oh, we have an emergency, we've got to respond, we've got to support this patient quickly. We don't have the equivalent yet in heart failure shock. No one's checking lactates in the patients that are sitting on the floor in unrecognized shock, and this is a problem. We also have to support the patient quickly after we find that they're in shock. And so seeing that they're in shock is only part of the problem. TMCS really addresses the left side of the screen quite well. So when you have a patient who's in hemodynamic failure with a fallen cardiac output and a rise in their SVR, they're starting to hypoperfuse, we can put an Impella in, we can put an ECMO in, we can do a lot to that patient. If they sit in that and they smolder and they become acidemic and lactatemic, I can't get them out of that nearly as well. That fallen SVR is not going to respond physiologically to the tools that I have, and it's really hard to pull them out of that shock spiral. And so we know that this time-based delivery of care is critical. These are Tarani colleagues out of Inova showing that there's a significant increase in mortality of about 9.9% for every hour that shock is recognized and untreated. And so that concept of the golden hour from trauma really applies to cardiogenic shock as well. We have to not just recognize it, we got to do something really fast once we recognize it. The other issue is, as Rand alluded to, not all shock is created equal. And so a lot of patients who present in cardiogenic shock have LV failure, but although they're a lot numerically, they're not a preponderance of the problem. Most of these patients have either BIV or RV shock by breakdown. So about 58% of these patients don't have LV only shock. Are there patients with biventricular shock that you can support with an LV only device? Absolutely, yes. But it's hard to tease those out. And that's a nuance that's hard to capture in enrollment criteria for these trials. This patient is not going to get better on an Impella 5.5. This is a patient that will crash on an Impella 5.5. And so when you put if you reduce this only to cardiac output, vasopressor, and systolic blood pressure, this patient could look just like a patient with LV shock. You enroll both of them in the trial, you're going to end up with another negative trial, and this continues to be problematic. And RV shock is only a fraction of the problem. This is Dr. Menon's slide. You saw these earlier. Shock takes many forms beyond LV and RV shock. So yes, there's the big acute LAD. There's also the Takotsubo that's dynamically obstructing. There's the mechanical complication with a PAP muscle, tamponade, severe AI from endocarditis. And then this patient with RV shock. Shock takes many, many forms in 2025. And if you lump these all in together, you're going to have another negative trial. We have to stop looking for the silver bullet of TMCS and start asking, how do we start doing platform trials that can answer the question in a more systematic way? Mortality is high in these patients. This is the other part of the problem is you say, hey, I only want to include sick patients in my trial. I'm trying to find the population that needs the benefit the most. Well, guess what? Those sick patients are the ones that have RV and BIV failure. And so the majority of our Sky Stage D and E patients are our BIV shock patients versus our LVs. LV only patients are a little bit less sick. And so even if you try to make your enrollment criteria more exclusive, you may run into a problem of enrolling patients that are not going to respond to LV only devices. This is why it's hard to study. We really can only fix LV dysfunction with the Impella 5.5, and which is really our workhorse mechanically right now. And if you only focus on that population and then you lump in a lot of these others, you're going to set your trial up for failure. These are, again, continuation of the data that Rand showed that mortality and prognosis is very different based on whether you're a heart failure shock patient or whether you're an acute MI patient. But how rapidly you develop this problem also matters. And so chronicity is a hell of a drug. So when you've got time to habituate to that fall in stroke volume and your end organs can accommodate to that drop in perfusion pressure, you're really set up to survive that shock insult much better than the patient who comes in with de novo shock. They behave a lot more like our patients with acute MI shock with a significantly higher mortality. But as in Greg's case, if you can get them through, their prognosis is great. How do you lump that in with all the other patients? It's really hard to tease this out. And if you elide the difference between these two populations, again, you're going to have a negative trial. So you run into type 2 error if you ignore the effect of chronicity. Lastly, or second to lastly, failure to gauge the differential heterogeneity or differential severity across your population. And so, again, thanks to Dr. Grant for giving us the language to talk about this. So looking at ECLS shock, they enrolled about 50% Sky Stage C. That's a patient population that we're not routinely putting on ECMO. And you lump them in with the rest of your trial and look at them. They have if you break out the Sky Stage Cs, you have an 8 to 10% mortality. Are you willing to put a patient with 8 to 10% mortality on a device with as many complications as peripheral VA ECMO, or do you want to look at other options? And if you don't include that and start breaking out that nuance in a systematic fashion, again, you're going to have a negative trial. We've gotten a little bit better at this, and gratitude to Dr. Kapoor at Tufts for giving us, formerly Tufts, for giving us a little bit more nuance here about sort of teasing out the effect of devices and drugs and helping to add a little bit more granularity to how sick these patients are, but it remains a constant struggle. Lastly, you can't spell TMCS without T. This is a temporary solution to what might be a permanent problem. And so these are bridges and not destinations. You need something on the other side of that river, whether that's recovery, whether that's VAD, or whether that's transplantation. All I want from my device is to decongest and perfuse my patient. I can't ask ECMO to provide anything beyond that. I can't ask my balloon to provide anything beyond that. So if I run into a patient that I can't recover or offer heart replacement therapies to on the other side, it doesn't matter how good my device is. I don't have a road out of the ICU and they're going to die over time. And so we have to be charitable when we interpret these results and say, my 6-month mortality might be awful, but really a device can only alter your 2-week or 30-day mortality, with the exception, as Vinu alluded to, of danger shock with some recruitment of salvageable myocardium. If a device can keep a patient alive long enough for me to safely complete an evaluation and get them to heart replacement therapy, that's all I need from the device. It's not its fault if I don't have an exit for them beyond that point. Moreover, I apologize for the mixed metaphor here, I'm really good at replacing the engine in a failed car, but cars have a lot of problems. So if you end up without a viable strategy because the wheels are gone and you end up with peripheral complications from the ECMO, or if you end up with long-term dialysis that precludes VAD in a patient that I can't offer heart kidney to, I don't have a long-term road out of here. And certainly if you're asleep at the wheel because you sustained a significant arrest and a lot of anoxic injury, I can't modulate your long-term mortality with anything that I can do. It's gone. What can we do instead? And so Rand alluded to these data. Shock teams are probably the answer right now. So a multidisciplinary shock team that can sort of break down this nuance and approach it at a level of granularity that a trial can't is probably the best answer that we can offer. And so we had the initial observational data showing improved mortality at the cost of more TMCS, but we're getting the right device into the right patient at the right time. We now have analysis from Alex Popoulos of the CCCTN database that said, when you look at centers that have shock teams and those that don't, what do? We reduce mortality. We actually deploy less TMCS, although we're more prone to reach for more advanced MCS with Impella or ECMO and fewer balloons, but that it improves mortality significantly. What do all shock teams have in common? So there are a few key things to talk about. The most important thing is that you identify shock early, you talk collectively early, you phenotype the patient rapidly, and then you support them as needed. I'm the director of our shock outreach here. I love getting on the phone with our referral centers and talking about these patients, figuring out how we can start stabilizing before they even get to us, run the hemodynamics and say, well, what tools do we have available? How can we start moving the needle on that patient before they even get to our door, and then make a plan for how we're going to more definitively support them and get them better in the long run. When you call us, you get these people on the line. So you get heart failure, cardiac surgery. So thank you to Dr. Zaki, our interventionalists, us from heart failure and from critical care cardiology, but it takes a village. And so you also get perfusion, critical care transport, and our transfer center on the line to sort out how we're going to get a patient over to here and how we're going to support them as quickly as we can. Are we going to do better? Does anybody know who this is? So this is E.O. Wilson. He's an entomologist and a sociobiologist. They asked him, are we going to have solutions to humanity's biggest problems? And I think, shock for me is one of my biggest problems. It's what I think about all day. He said, yes, if we are honest and smart, but that our real problem is that we have Paleolithic emotions, medieval institutions, and godlike technology. And I think more or less that's how hospitals run now. And so we have care delivery systems from the last century that are trying to tackle a problem where technology has advanced dramatically in the past 5 years, and we're looking at more on the horizon. And so, we have our work cut out for us, but I'm optimistic. There are trials enrolling every day for advanced MCS support. I'm looking forward to Impella BTR as it comes out, but in the meantime, we're really reliant on increasingly registry data that can ask more nuanced questions, admittedly not in a very prospective fashion, but can offer the end that a single center experience just can't. And so, I think we're getting better, but we still have a long way to go. If it's any solace, MCS is not alone in this space. And so certainly we don't have RCTs supporting Impella in most contexts. We don't have RCT supporting ECMO in most contexts, but look around the ICU. Look at your inotropes, your vasopressors, your anticoagulation. We have a big battle ahead of us, not just for our MCS, The PAX trial is coming out someday, hopefully. I hope it's positive. I'm not optimistic, but we will see. But right now, we're reliant on the fact that I think most of us believe in these things. And, you know, MCS is just one of a host of many things where we don't have very granular guidance. So thank you all. Thanks to Anne, help with some of these slides, and I'm happy to take any questions.
Thank you so much. I think we have time for one very quick question. I'm just looking to see if there are any from the audience. If not, I'll ask a super quick question, direct it to Dr. Menon just to round out here. You know, one of the more controversial things about the lovely ACS guidelines that you're involved in was that class 3 recommendation for no routine use of the balloon pump, and particularly the VA ECMO. And of course, as we just heard pointed out by Dr. Higgins here, we have no intention to use VA ECMO in a routine patient. How do we communicate across the board to our colleagues where we do use ECMO and where it still has a role?
Yeah, I think that's a really tough question because I think, you know, a lot of people in Europe don't have any balloon pumps in their lab anymore. And how do you tell a clinician who has just put a balloon pump in somebody and knows he's going to sleep that night because the person's not going to have angina or the blood pressure has just gone up and stabilized, that they're doing something that is really wrong? And I think that's the part where clinical trials and academic randomized clinical trials just don't align. I think all of us have seen that targeted response with an intra-aortic balloon pump that works. And so I think the guidelines get away with that word routine, but the person reading it does not interpret routine as routine.
Yeah,
and so I think we really need to understand that that's just a nuanced, true statement. But the implications of that is not that you're a bad doctor if you were then to use a device appropriately.
Yeah. Well, thank you ever so much. We'll wrap there, but I do just need to congratulate our raffle winners. So thank you, everybody, for going around and seeing our exhibitor booths. And give a wave if you're here, and then head on out to the registration desk to pick up your prize. Starbucks cards going to Abigail Shaw and Angelica Kessler. The AirTags going to Andrea Ningard, the AirPods to Michelle Bringinger, and the Apple Watch to Russell Piazza. So we're delighted to hand those out. Well, thank you so much for all being here. It's been a wonderful couple of days, and we really appreciate all your energy and input. Thank you so much.